Good afternoon, everyone, respected seniors, colleagues, and dear postgraduates. On behalf of IADVL Andhra Pradesh, we have taken up this prestigious project of PG clinics. We plan to do it once in every month. Our aim is to inculcate and improve clinical skills among the postgraduates of dermatology, venereology, and leprology. Our first PG clinic is taken up by Dr. P. Guruprasad sir, Professor and HOD of Andhra Medical College. Thank you very much, sir, for volunteering to do this. Sir is our internal examiner for today. We are very privileged to have a very distinguished personality as our external examiner, none other than Dr. S. Anandan, Professor and Dean of Students, SRMC and RA Chennai. Thank you, sir, for accepting our invitation. Our presenters for today are Dr. Ramiza, final year postgraduate, Andhra Medical College, and Dr. Nandini, final year postgraduate, Andhra Medical College. Now, I request our President, Dr. Attota Kavita, to give the presidential address.
Good afternoon and warm welcome to all of you. On behalf of IADVL Andhra Pradesh, we are happy to start the PG clinics. I hope it will bring a complete overview of the clinical exams. This is the idea of Dr. Sitaram sir. We wanted to carry on with the long cases, short cases, and the spotters also. The 12 months we are going to have it. And apart from this, we are planning good academic activities like quiz programs for the postgraduates and even webinars, which are useful both for the postgraduates and the practitioners. And I request all the PGs of our IADVL to become the members of PLM so that you can avail the facilities of the IADVL, both state and central facilities. And we are very honored to have the legendary personality, Dr. S. Anandan sir, as our external examiner. And we are also very excited because we couldn't hear sir when we are our postgraduates, but we are lucky now to have him. Thank you, sir, for accepting and kindly. Yes, and our beloved Dr. Guruprasad sir is the internal examiner for today. And without much ado, I hand over the proceedings to Saujanya. And on behalf of the IADVL, I wish you all a happy learning. Thank you.
Thank you, madam. Now I request Dr. K.S. Divya to introduce our examiners and take over the proceedings. Over to you, Divya.
Good afternoon, everyone. We have Dr. S. Anandan sir as our external today. Sir is a very dynamic teacher and sir needs no introduction. Sir did his MBBS and MD dermatology from the prestigious JIPMER Pondicherry University. Sir worked there as a registrar for 1 year and then sir worked as a project coordinator at VHS Adayar, and then sir joined Sri Ramchandra Medical College in 1986. There, sir worked as an assistant professor, associate professor, then professor and HOD, deputy medical superintendent, professor, dean, and now sir is as dean of students there. Sir has a total UG teaching experience of 41 years and PG teaching experience of 38 years. Sir is a president of IADVL Tamil Nadu branch 2011. Sir has many papers and guest lectures to his credit. Sir has delivered Sardar Memorial Oration, Dr. Rajendran Memorial Oration, Dr. Shobhanadri Memorial Oration, Amala Oration, Dr. Shivakumar Oration, and Sir received Teacher Par Excellence Award in IADVL National Conference, Jaipur in 2012. Sir received Lifetime Achievement Award in IADVL Telangana, Tamil Nadu 2019.
Patrick Esudian Oration.
Sir also delivered Patrick Esudian Oration. Sir has 62 publications to his credit and has authored many books and dermatology chapter in disease of skin in book of pediatrics, disease of oral mucosa in pediatric dermatology textbook, regarding oral lichen planus in lichen planus monogram, regarding ecology of skin diseases in India in PG textbook of dermatology, and sir is the editor of PG textbook of dermatology. Sir is examiner in almost all medical universities. He is the examiner in AIIMS, JIPMER, PGH Chandigarh, University of Delhi, Dr. NTR UHS, Dr. Tamil Nadu, Dr. MGR Medical University, Kerala University, and everywhere. Sir is the Inspector of National Board of Examiners and he is an external expert for selection of faculty for JIPMER, Pondicherry. And our internal today is Dr. P. Guruprasad sir. He is the Professor and HOD of Andhra Medical College. Sir did his MBBS in Andhra Medical College and MD in Rangaraya Medical College. Sir joined as Assistant Professor in Andhra Medical College and then Associate there and Professor and HOD in RIMS Government Medical College. And now Sir is currently working as Professor and HOD in Andhra Medical College. Sir worked as Secretary IDVL Andhra Pradesh in 2011 and President IDVL AP in 2018. And Sir is a Scientific Committee Chairperson for Dermazone South 2022. Sir has 30 publications to his credit. And without much ado, we will go into the presentation. Now I request Dr. Ramiza. Ramiza. To present the case. Please. Audience can ask the questions by putting their questions in the question box. And those questions will be discussed at the last by our examiners. You can put your queries there. You have an audience link.
Yeah, yes, doctor, you can start presenting.
Okay, sir. Good afternoon, everyone. Respected professors, seniors, and postgraduate. I'm Dr. Ramisa A. and Dr. Nandini, final year postgraduate from Andhra Medical College, Visakhapatnam. We are here to discuss a long case discussion on systemic sclerosis. A 26-year-old unmarried female hailing from Visakhapatnam came with chief complaints of painful bluish discoloration of fingers on exposure to cold and tightening of skin and difficulty in opening mouth since 1 year. Difficulty in swallowing and regurgitation of food and breathlessness on exertion since 6 months. And she had her exacerbation of symptoms from the past 1 month. History of present illness. The patient was apparently normal 1 year back and she developed pain on fingers on exposure to cold, which was more during the early morning. And she then noticed bluish discoloration of fingers associated with it. The discoloration lasted for a few minutes, initially relieved on covering with a towel or blanket, and later relieved on keeping the hands in lukewarm water. The frequency of episodes increased with the routine activity and was interfering her daily routine. Patient developed ulcers over fingertips, and the ulcers healed within a span of 10 days, and it healed with scarring. Patient also started developing tightening of the skin involving both hands and feet, which progressed proximally, and it was associated with itching. She also noticed tightening of skin over the face, which gradually she developed difficulty in opening mouth. She also noticed altered pigmentation of skin over upper back, hands, and elbows. She developed burning sensation associated with food intake and developed difficulty in swallowing more to solid foods, and she had to take small bites of food with sips of water in between. Patient also noticed difficulty in breathing during climbing stairs, washing clothes, and which was relieved by taking rest. So patient attended KGH DVL OPD with these complaints and was started on specific treatment. But the patient was on irregular follow-up and stopped treatment on her own. And from the past 1 month, she had exacerbation of her symptom and again attended our OPD. There is no history of any photosensitivity, fever, or oral ulcers. No history of any difficulty in waking up from sitting position, combing of hairs, or muscle pain. No history of any grittiness of eye or dryness of mouth.
Dr. Samina, for the sake of postgraduate, why did you ask for photosensitivity, fever, and oral ulcers?
To rule out any other connective tissue disorder, to rule out SLE, sir, we
Specific,
asked
specific.
SLE.
SLE. So SLE can have all these symptoms along with photosensitivity, fever, and oral ulcers. Very good. Any difficulty in waking up from the sitting position or combing hair? Where did you ask?
Sir, to rule out any proximal myopathy as in dermatomyositis.
Very good. So there may be association of scleroderma with SLE or scleroderma with dermatomyositis. It's very apt that you have asked these questions. Grittiness of the eyes and dryness of the mouth. What did you ask?
Rule out Sjogren syndrome, sir.
Excellent. Excellent. Very good. So your history is almost complete.
Sir.
Good. Proceed.
No history of any joint pain.
If the patient has joint pains in scleroderma, what type of joint pains the patients can have?
Two types, like non-inflammatory myositis and inflammatory arthritis is also seen, sir. So,
Like rheumatoid arthritis, they can have joint pains. Very good. Right.
no history of any hard raised lesion with chalky discharge or ulceration, sir.
What is this for?
For calcinosis cutis, sir.
Okay. Very good. Right.
No history of chest pain, palpitation, or hemolysis. Patient
Yes.
can have cardiovascular and pulmonary artery hypertension, sir. So to rule out that, chest pain, palpitation, and hemolysis.
Very good. Right.
No history of decreased urine output, frothy urine, hematuria. No history of headache, visual disturbances, seizures. Patient can have a scleroderma renal crisis, sir, which can present with a renal failure, headache, encephalopathy, seizures. So to rule out that.
Yeah, good.
No history of vomiting, hematemesis, abdominal pain, diarrhea, or constipation.
Okay.
Patient.
Do you think diarrhea and constipation can be clinical features of scleroderma?
Yes, sir. Due to GI involvement, patient can have diarrhea and constipation.
Alternate diarrhea and constipation is one of the features of scleroderma. If GI tract is involved, they can have alternate constipation and diarrhea. During the course of discussion, we'll ask why constipation and why diarrhea. We'll come to that after you present the case.
Okay, sir.
Yes.
No history of any drug intake prior to the onset of skin disease, sir.
Yeah. Keep presenting.
No history of any exposure to radio contrast dye or scan taken prior to the skin disease onset.
Why did you ask this question?
To the pseudoscleroderma conditions are nephrogenic systemic fibrosis.
Yeah, nephrogenic systemic. Right. Very good. Right. Okay.
No history of organ transplantation or blood transfusion.
This is a very important thing. I remember as a postgraduate, my long question was graft versus host disease, GVHD. So there, the late manifestation of GVHD is sclerodermoid pattern. So very good, excellent, right.
Sclerodermoid pattern. Chronic graft versus host disease. No history of exposure to pesticides, coal mines, or welding fuels.
Yeah, keep presenting.
No history of any blisters. No history of blisters in the skin. No history of any trauma, intense physical activity prior to the onset of disease. Past history. No similar history in the past. No history of diabetes, hypertension, bronchial asthma, coronary artery disease, cerebrovascular disease, TB, epilepsy in the past. No history of any recent vaccination. Treatment history. The patient was started with tab azathioprine 50 mg BD, tab losartan 25 mg OD, tab pando 40 mg OD, and tab domperidone 10 mg BD. But patient used the treatment for 3 months and stopped on heroin. Family history. No similar history in the family. No history of any chronic illnesses in the family.
Was she feeling better when she was taking treatment? Were the symptoms improved when she was taking this treatment?
Relief of symptoms during treatment.
She reported improvement?
Yes, sir.
Yeah, okay. Continue. Right.
But patient stopped on heroin.
No problem. Yeah.
Personal history. Consumes mixed diets, no known allergies to drug or food. Menstrual history, regular cycle, and unmarried and no history of any sexual exposure. On general examination, Patient is alert, conscious, cooperative, oriented to time, place, and person. Moderately built and nourished with BMI of 19, weight 48 kilogram, pulse rate of 86 beats per minute, respiratory rate 20 per minute, thoraco-abdominal, pallid present, no cyanosis, generalized lymphadenopathy or edema. And on dermatology, the skin or the face looks taut. There is decreased wrinkling present, obliteration of the nasolabial fold, and microstomia seeds. And the patient is able to insert only 2 fingers, so microstomia grade 2 present, sir.
Okay.
There was difficulty in retracting
how
the
many
lower
fingers?
eyelid, so Ingram
Normally, how
sign
many
positive.
fingers? Normally, how many fingers can a patient insert?
4 fingers,
Okay.
sir.
4. So there is a definite restriction of the mouth opening.
4 fingers normally, sir.
Yeah, please. What is Ingram sign?
Then salt and pepper.
Yes, sir.
Ramesh sir.
Difficulty in retracting the lower eyelid, sir.
Ramesh
Okay,
sir.
good, right,
Due to sclerosis.
right. Very good, very good. Right.
Sir. Sir.
Asking about Ingram sign.
Salt and pepper. Sir.
Yeah.
Unable to retract. Patient is unable to, we are unable to retract the lower eyelid, sir.
Yeah, correct, correct.
Because
You're
of
right, you're
sclerosis.
right.
So Ingram sign is
Proceed.
positive in this patient, sir.
Yeah, proceed.
Salt and pepper pigmentation are present over the extensor aspect of bilateral forearm, elbows, upper back, and hands. Digital picket scar are seen over the fingertips.
Yeah.
Finger flexure contractures are present. And nail fold capillaroscopy. On the left side, it is the normal capillary, which is regular. And in our patient, we found there are tortuous and dilated capillaries are seen on nail fold capillaroscopy.
Very good.
And the skin tightening is present over fingers. It's extend to bilateral mid upper arm, bilateral feet, which is joints, no swollen or tender joints, no tendon fiction rub, and oral cavity, no ulcers, telangiectasias or difficulty in protruding tongue, nails normal, scalp and hair normal, mucosas are normal, genitalia normal. On systemic examination, respiratory system, on inspection, respiratory rate was 20 per minute, which was thoraco-abdominal. Trachea appears to be central. Chest movements are bilaterally equal and no chest wall deformities. On palpation, the inspection findings are confirmed and with a chest expansion of 2.5 centimeter at the level of nipples.
Is it
Percussion,
restricted?
resonant notes
What
were
is the
heard all over the
normal
lung
expansion?
area.
What is the normal expansion?
5 centimeter.
Okay, so there is a
5 centimeter
definite
at full
restriction.
inspiration, sir.
Yeah, there is a restriction of chest expansion.
Yes, sir.
Yeah.
Sir. On auscultation, vesicular breath sounds heard over lung area and cause crepitations heard over bilateral infrascapular areas.
Yeah.
Cardiovascular system, S1, S2 heard normally, no palpable or loud P2 and no murmur. Gastrointestinal system, per abdomen soft, non-tender, no organomegaly. Central nervous system, higher mental functions normal, no focal neurological deficit. Musculoskeletal system, no muscle tenderness, bulk, tone, power are within normal limits. So with the clinical features, we came to a professional diagnosis of diffuse systemic sclerosis with pulmonary involvement, sir.
Okay. Yes. Proceed. How did you investigate this patient?
On routine examination, hemoglobin was 10.1 gram, total count was 5,400, platelet was 1.7 lakh, ESR 25, RFT, LFT was within normal limit, screening HIV, HBsAg, HCV and VDRL was non-reactive. Thyroid function test was found to be normal. Complete urine examination was within normal limit. Rheumatoid factor was negative. LDH and creatine phosphokinase was within normal limits. And on doing upper GI endoscopy, we found lax lower esophageal sphincter. USG abdomen showed normal study. 2D echocardiogram also showed normal studies. Chest X-ray PA view showed bilateral reticulonodular opacities in the lower zone. And HRCT chest showed bilateral reticular opacity with ground glass opacity and honeycombing seen in the lower lobes. And pulmonary function test showed a restrictive pattern. On ANA was positive with a titer of 1:80, and on profile, the SCL70 antibody was positive. On biopsy from thickened skin showed epidermis showed focal mild atrophy with upper and deep dermis showed mild increase in collagen bundle. There was no evidence of sebaceous glands or hair follicle were seen. So with the 2013 ACR ULAR criteria classification, our patient had skin thickening of the fingers of both hands extending proximal to the metacarpophalangeal joint, sclerodactyly, pitting scar, abnormal nail fold capillaris, interstitial lung disease, Raynaud's phenomena, systemic sclerosis related autoantibodies. So with a score of 26, patient had a definitive systemic sclerosis. So my final diagnosis is diffuse systemic sclerosis with pulmonary involvement.
Very good. Yes. Okay. Your presentation is excellent. And for the information of the postgraduates, if you can present a case of scleroderma, a long case, like what Dr. Rabisa has said, I think you are halfway through. Wonderful presentation. You have covered extensively, both in the history and the clinical examination and the investigation which you have to do. You have almost covered everything. I need to congratulate you for doing a wonderful job of presentation. Now let me start. Let me start my questions. You said you started off with bluish discoloration and pain.
Sir.
What is that? What is that bluish discoloration and pain?
Raynaud's phenomenon, sir.
Define Raynaud's phenomenon.
Episodic vasospasm of digital arteries involving fingers and toes, which on exposure to cold, emotional stress or emotional stimuli, characterized by a triphasic response of pallor, cyanosis, and erythema. Sir.
Okay, it is an acute episodic triphasic phenomenon. It is acute triphasic.
Triphasic.
What is the bluish discoloration due to? Cyanosis due to?
Cyanosis due to vasoconstriction, sir.
Very good. What is the pallor due to?
Pallor due to vasospasm, sir.
And erythema, reflex erythema?
Due to vasodilatation, sir.
Dilatation. There is an arterial dilatation after the pallor. That's why it becomes red, erythema. Cyanosis, pallor, and erythema are the three phases of Raynaud's phenomenon. What are the conditions you get Raynaud's phenomenon?
In connective tissue,
okay.
Primary Raynaud's is there, secondary Raynaud's is there, sir.
Yeah. We talk about second.
Okay. Connective tissue disorders like SLE, systemic sclerosis, Sjogren syndrome, dermatomyositis, sir. APLA.
Rheumatoid arthritis you can include.
And the phospholipid antibodies.
Yeah.
Then arterial diseases like atherosclerosis, thromboembolism, thromboangiitis obliterans, thoracic outlet syndrome, sir.
Excellent. Yeah, cervical rib or thoracic outlet syndrome. Yes.
Sir, drugs like
occupational Raynaud's phenomenon.
Vibratory objects, sir.
So the people who mechanics vibratory tools, they can also develop, or you have already explained everything. And even usage of pesticides also you have mentioned. Occupational vinyl chloride disease also can present as Raynaud's phenomenon. What is Raynaud's disease then?
Raynaud's disease is primary Raynaud's phenomena, sir. It presents in there will be a family history. The onset will be at a younger age. The number of episodes will be less, and there is no associated any digital ischemia or digital ulcers. And nail fold capillaroscopy will be within normal limits, sir.
Okay, Raynaud's is exclusively a disease of females. It doesn't come in males. It's a disease of females. Okay, Raynaud's phenomenon. How do you manage? How do you manage Raynaud's phenomenon? Because Raynaud's phenomenon can be a short note in your examination.
Sir.
How do you manage Raynaud's phenomenon?
Initially, we ask the patient for protection, sir, use of gloves
Yeah,
and socks,
fine, correct. Yeah,
avoiding of smoking, caffeine intake, sir.
yeah.
And we protect, avoiding of jobs which cause injury or trauma to the hands, like typewriting.
These are all preventive measures.
Sir.
What is the drug treatment?
Uh, Initially, we can start with calcium channel blockers, sir.
What is the drug of choice?
Nifedipine, sir, 10 mg TID we can.
Nifedipine. What is the common side effect of nifedipine?
Lower esophageal sphincter will be relaxed, sir. So,
Upper GI endoscopy, there is a lax
lax
sphincter.
esophagus.
So you like to start nifedipine in this patient?
So, sir.
So there may be some problems. So please remember that. But nifedipine is a drug of choice. What are the other drugs?
Angiotensin receptor blocker like losartan, 25 to 50 mg can be given, sir. Then phosphodiesterase 5 inhibitors like sildenafil, 25 to 50 mg TID, tadalafil, 20 mg
What is the other use of sildenafil in scleroderma?
in pulmonary artery hypertension.
Pulmonary artery hypertension also, sildenafil is a very useful drug. Okay, then
Endothelin receptor antagonists like
Bosanta.
and 62.5 mg BD, ambrisentan and macitentan can be given.
Okay, very good. Then acute Raynaud's.
Then prostacyclin analogs like iloprost,
Prostacyclin.
IV iloprost or inhaled iloprost.
Yeah.
And 5 to 2 nanogram per kilogram per minute for 3 to 5 days.
Very good. Pentoxifylline, what is the role of pentoxifylline?
Pentoxifylline vasodilatation.
So peripheral, it can also be used. It may also be used in Raynaud's phenomenon. What about aspirin?
Aspirin can be used, sir. Warfarin, low molecular weight heparins can be used, sir. Antithrombotics.
So many drugs can be used. Prevention of Raynaud's phenomenon is better. You said digital ulcers. Well, are they painful or painless?
Painful.
How do you manage digital ulcers?
Hydrocolloid dressings can be given, sir. And then analgesics, then aspirin, low molecular weight heparin, sir.
What is the topical treatment of digital ulcers?
Topical glyceryl trinitrate.
Excellent. 2% nitroglycerin ointment. What is the side effect of nitroglycerin ointment?
Hypotension.
Reflex headache. Reflex headache. Patient can develop headache because it produces vasodilatation, can be cerebral vasodilatation. Tell the patient there can be headache when you apply nitroglycerin ointment. And stellate scars. When it leaves behind, it heals with stellate scarring, which is the future of scleroderma. Any drugs which can induce Raynaud's phenomenon?
Drugs like bleomycin,
Yeah.
OCPs, beta blockers, ergotamines.
Ergot. So very, very important. Ergot is a drug which can cause Raynaud's phenomenon. Very good. Right. Excellent. And in the investigations, no, you said investigations, respiratory system, X-ray chest. You didn't mention about X-ray chest. You've gone into HRCT. Normally we do X-ray chest just for completion sake. You have almost finished everything. Actually, you've done everything. X-ray chest. And then improving upon the X-ray chest, you do a high resonance CT. Pulmonary, what is DLCO in pulmonary function test?
Diffusion lung capacity to carbon monoxide, sir.
Excellent. Very good. So normally you get a restrictive pattern. What is FEV1? FEV1, restriction of FEV1 is a feature of pulmonary function test in scleroderma. What is FEV1?
Post expiratory volume in 1 second.
Excellent. Very good. So in cardiovascular system, you talked about ECG, you talked about 2D echo. So if you got 2D echo, sometimes you can pick up a pulmonary artery hypertension. If there is a pulmonary artery hypertension, how will you confirm?
Right heart catheterization is the
Excellent.
right.
Very good. Very good. Pulmonary artery catheterization will confirm pulmonary artery hypertension. So that's why in your clinical examination, I was very happy. You have mentioned about no loud P2. I always keep telling my PGs, apart from S1, S2, in scleroderma, you must mention about loud P2. Because clinically itself, when you put your stethoscope in the pulmonary area, you can pick up loud P2. What's the treatment of pulmonary hypertension?
endothelin receptor, and one
Yeah.
is Bosentine fibril.
Sildenafil
Sildenafil,
is a
phosphodiesterase.
very good drug for management of pulmonary arterial hypertension. Anyway, you are going to have a multidisciplinary cardiologist helping you out with management of pulmonary arterial hypertension. Very good, right? GI tract. You have talked about endoscopy. Am I right? Okay, endoscopy. What other investigations you can do pertaining to GI tract?
Esophageal manometry,
Esophageal pressure recordings in there. So that can be a feature. Yes.
barium swallow can be.
Barium swallow and follow through. Barium swallow, and we are not doing nowadays. Most of the people go for upper GI endoscopy. Barium swallow. In what position you advise barium swallow to a patient of scleroderma?
Left anterior.
Stand in birth position. You should not make the patient stand erect and give barium swallow. It will run down. What's the deformity? What's the picture, clinical picture of the barium swallow in scleroderma?
Glass appearance of esophagus.
Rat tail deformity in esophagus, watermelon stomach.
Watermelon.
And follow through, what else you get?
Valvular conniventous.
Excellent, very good. Diverticular, multiple diverticular, where the food particles can go and stay. Because of the putrefaction, the patient can have diarrhea. Because of the low motility, patient can have constipation. That answers your clinical presentation. Patient can have alternate constipation and diarrhea. So, barium swallow and follow through. Don't forget in management. Very good. Then what about renal? Any other specific investigation? Urine
Extraction,
spot test for urine protein creatinine. That can be there. If it is high, you can go for a 24. Normally in SLE, we do a 24-hour urine protein. Am I right?
Sir.
So, scleroderma, also if renal involvement, 24-hour urine protein. Ultrasonogram also can tell you about the size of the kidney and other things. Then urine 24-hour creatinine clearance. Urine 24-hour creatinine clearance is a very specific test for renal function. If available, you can get it done. You can get it done. Did you take an X-ray of the hands?
No, sir.
So that also will help. That also, the completion sake, you've done everything. Patient has got contractures sclerodactyly. X-ray of the hands will probably complete the whole gamut of investigations which you have done in this patient.
Okay.
Very good, right? Use it biopsy. No? Urine, there was epidermal atrophy and collagen bundles, increase in the collagen bundle. You didn't find any apocrine or ecrine structures. No?
Sir.
Very few maybe get. What is that typical histopathology?
Oasis in desert signs.
Good. Oasis in a desert appearance and high uptake of apocrine. This is a very important feature in scleroderma. Right.
Sir.
Now we have covered almost everything about the clinical Raynaud's phenomenon, the clinical features, the investigations pertaining to system you do, and then you talked about antibodies. ANA can be ANA is positive in this patient. Then you also said about anti-centromere antibodies being present positive in this patient. Am I right?
Anti-SCL70.
Yeah, and anti-SCL70. Anti-SCL70. You did a LDH and CPK for what?
Muscle involvement to look for certain.
Muscle involvement is there. Okay. Suppose the patient has overlap of dermatomyositis. What other investigation you have to do? Suppose there is a weakness. This patient did not have any weakness of getting up from sitting position, standing position, or combing the hair. Suppose she has weakness.
EMG, CPK, LDH, muscle biopsy, T2-weighted MRI.
And MRI. Muscle biopsy, how do you choose a muscle for muscle biopsy in dermatomyositis?
Involved muscle.
MRI scan. You must use the MRI and then scan the muscle for weakness. Muscle biopsy, how do you send the specimen for pathology lab? How do you send the muscle biopsy?
No.
Do you have any idea?
No, sir.
Because once you take the muscle for biopsy, it will curl. You have to tie to the end of the glass rod. glass rod. No, you have to tie the ends. And Zenker's medium, Zenkers, Zenker's medium to send conceptual biopsy and characteristic feature of dermatomyositis we can get in if dermatomyositis is present. Very good, right? And your very classical honeycomb appearance you got in the lower. Excellent, very good. So you covered almost everything about that. And now we go into the treatment of this scleroderma. The patient was started on azathioprine, losartan, and pantoprazole with this thing. Suppose I ask you this question: how do you manage scleroderma? What will be your answer?
Sir, for this patient had a lung involvement, ILD, sir.
ILD, how do you, no, in general, I'm asking you, how will you answer the examiner? How do you manage this patient? How will you answer?
Yes, generally we'll tell for physiotherapy.
Supportive measures will come later. Specific therapy.
For skin involvement, only if skin sclerosis is there. If it is mild,
skin sclerosis, then
if it is mild, we can start with methotrexate, sir.
See, there is a vascular component.
Sir.
There is a fibrotic component.
Sir.
And the systemic component. So the management is you have to manage the fibrosis, skin thickening. You have to manage the vascular component, which is in the form of Raynaud's phenomenon, which we discussed at length. What are the various drugs used in the vascular component? And third is individual systemic involvement. Suppose kidney renal is involved, then it's a separate management. This patient has got ILD, presumptively interstitial lung disease. So you have to manage the ILD. We'll come to ILD. Now, how do you manage the fibrotic component? What is the drug used to treat the fibrotic component in scleroderma?
Method for skin fibrosis.
Skin fibrosis. Yeah.
Methotrexate and mycophenolate mofetil can be given, sir.
Okay, methotrexate 7.5 to 10 milligrams it can be given. Mycophenolate mofetil can be given. Yes, then
PUVA therapy, UVA1 therapy.
UVA1. What is UVA1? Long PUVA. It's called as long PUVA. What is UVA1? What is the wavelength?
392.
Long UVA. What is the wavelength of the
292.
342, 400. Why do you want a longer wavelength?
Deeper penetration.
Deeper penetration.
Excellent, very good. So longer the wavelength, deeper the penetration. Because of thickness, you need a long UVA1 also can be used. What was the drug which was earlier used for treating the fibrotic component, skin fibrosis?
Penicillamine.
Very good. Deep penicillamine. What do you know about something about the deep penicillamine?
Copper chelating
agent.
Good. So the
collagen.
deep penicillamine is copper poisoning, copper chelation. Which condition it is primarily used?
Rheumatoid arthritis.
When there is copper excess. Some disease.
Wilson's.
Wilson's disease. Primary use of deep penicillamine. There are nearly 10 or 11 patients in our institution. Wilson's disease. For years they have been taking deep penicillamine. Now deep penicillamine is almost given up. Only those patients are taking deep penicillamine. What's the dosage?
125 mg BD.
250 milligrams. 250 milligrams PD or TDS. Why is the deep penicillamine important to a dermatologist? What is interesting about deep penicillamine to a dermatologist?
Then not again side effects.
It degrades collagen.
Okay, what are the side effects? Cutaneous side effects of it has got specific cutaneous side effects. That's why it is interesting to a dermatologist. Can you name some cutaneous side effects of deep penicillamine?
Lupus erythematosus, sir. Bullous pemphigoid, lichen planus.
Pemphigus. Bullous pemphigoid, exacerbation of SLE. Then
Pseudoxanthemoelastic.
excellent.
Serpingerosis.
So that is why I just asked about deep penicillamine. Nowadays, almost dermatologists have stopped using deep penicillamine. There are only old timers who are using deep penicillamine. They have moved out to methotrexate and mycophenolate mofetil. What is the dose of mycophenolate mofetil?
2 gram per day, sir, can be given, sir.
That's like
35 to
2 grams per
45
day.
mg per kg per.
What's the advantage of mycophenolate mofetil? What's the advantage? There are so many drugs, but what's the advantage? One advantage of MMF.
It will act for liver.
Good safety
Like-
profile.
Good safety.
Good safety profile. Suppose you are using cyclosporin. Earlier, we used to use cyclosporin for many skin conditions. You have to monitor blood urea, sugar, creatinine, check the BP and other things. Whereas with the MMF, it has got a good safety profile and much cheaper than cyclosporin. What are the indications of MMF in dermatology?
Immunobullous disorders, sir.
Okay, immunobullous disorders. No, just prepare yourself. MMF can be because pharmacology, dermatopharmacology, MMF can be a short note.
Yes.
Recently, you always classify vasculitis, bullous disorders, connective tissue disorders, SLE, scleroderma. Like that, if you can classify, so many things will come. Psoriasis, lichen planus, papilloscomus diseases. You classify, with eating an eyelid, you'll be able to rattle out 8 or 10 conditions where MMF is used. Okay, right. Good. So fibrotic component, vascular component, you have already discussed about Raynaud's phenomenon. Interstitial lung disease is often talked about, and lot of clinical material is available about ILD. How do you manage ILD?
Cyclophosphamide is the drug of choice for this.
Earlier, cyclophosphamide drug of choice, yeah, 50 milligrams twice a day can be given. What's the side effect of cyclophosphamide? Suppose a patient taking cyclophosphamide comes to your OPD, what investigation will you do from time to time?
Monthly CBC should be done, sir. Then
What is
blood
CBC?
should be done.
Urine cytology.
Urine cytology should be done.
For RBC, microscopic exam. What is it called as? Microscopic hematuria. Why it happens?
Acrolein.
Cystitis.
Excellent. So it is due to hemorrhagic cystitis, which is due to the byproduct of the alkaline. How do you prevent?
Messner, sir.
Hydration. Basically, hydration. We talked about the textbooks mentioned Mesna. It is much more complicated giving Mesna. Better hydration. Good hydration when a patient is taking cyclophosphamide itself is important. How else you can use cyclophosphamide? Apart from using 50 or 100 milligrams daily, how else you can use cyclophosphamide?
IV can
IV cyclophosphamide, how many milligrams?
600 milligram per meter square monthly. For
Very
6
good.
months.
What is this called as?
Pulse
High doses of
injection.
cyclophosphamide. Ablative doses, especially renal involvement in SLE or scleroderma, ablative doses of cyclophosphamide. And the nephrologists are of the opinion the pulse cyclophosphamide given IV has got much less side effects compared to daily cyclophosphamide. This is for information. Okay, you can use, what else you can use for ILD?
MMF can be.
Yeah, nowadays most of the rheumatologists are giving MMF. They are not using cyclophosphamide. Methotrexate can be used, but MMF is, and low dose steroids. What is your opinion about low dose steroids or steroids in scleroderma? Do you want steroids in scleroderma?
In early edematous phase and serositis phase, we can use low dose.
Low dose steroids. I
Uh,
learned it at the Scleroderma World Conference. Never use high dose steroids. Even though earlier pulse therapy, it used to be mentioned scleroderma can be indication. Never use high dose steroids. Why?
Renal
can precipitate a scleroderma renal crisis.
Excellent. So if you never down 10 to 15 is the maximum dose of prednisolone. Early inflammatory stage. When there is a early inflammatory and late sclerotic stage in scleroderma, if a patient comes with early inflammatory with edema and other things, low dose steroids. And most of the pulmonologists, apart from MMF and cyclophosphamide, they always use low dose steroids. 10 milligrams on prednisolone is given. Never use high dose steroids. Then what else?
Fibrinolytic agents like pirfenidone.
Okay.
Then tyrosine kinase inhibitors like nintedanib.
Respiratory physiotherapy is important.
Yes.
You must give active physiotherapy. It's also very important. Very good, right? Okay. And what is the renal involvement in scleroderma?
The patient can have scleroderma renal crisis, sir.
Yeah.
It-
Not necessarily that all patients should have renal crisis. It's a
Sir.
rare complication. But normally, what can they have? Malignant hypertension.
Hypertension. Renal crisis.
Malignant hypertension. Because of glomerulosclerosis, they can have malignant hypertension. How do you manage the renal involvement in scleroderma?
AC inhibitors.
AC inhibitors. What are the AC inhibitors?
Captopril, enalapril,
What is the common cutaneous side effect of AC inhibitors?
angioedemas.
Very good. Urticaria and angioedema can be a problem, and a persistent cough. Symptom-wise, some of the patients started on AC inhibitors can have persistent cough, dry cough. Unless you stop the medicine, they'll continue to cough. You should remember that. Okay, right. It almost covered everything. Good that a very important point I want to mention. You mentioned about CNS examination and also mentioned no focal neurological deficit. No focal neurological deficit is very important. Okay, what is overlap syndrome?
Overlap patient will have clinical features of more than one autoimmune rheumatological disease, sir. Like most commonly systemic sclerosis with the SLE, rheumatoid arthritis, dermatomyositis, Sjogren syndrome, or polymyositis.
Okay, that is overlap.
Sir.
What is mixed connectivity disease, MCTD?
It's a type of overlap syndrome with the U1 RNP antibody positive, sir.
Suppose I ask this question. Somebody is giving a punishment to have SLE or MCTD, which is better?
MCT.
Why? We should not have neither MCTD nor SLE, but prefer MCTD. Why? The involvement is much lesser in MCTD, whereas one of the important involvement and cause of morbidity and mortality in SLE is renal involvement. MCTD is an important thing. You can put a mark into mark. MCTD can be a short note.
Sir.
So you talked about overlap. You talked about MCTD connectivity. What is UCTD?
Undifferentiated connectivity. The patient will have clinical features of one connective tissue disorder, sir, but it will not fit the diagnostic criteria.
Excellent. It will not meet the criteria. As later you said, no, you'll have criteria. It will not fulfill any full criteria of any disease. It may have one criteria of this, one criteria of that. That is undifferentiated connective tissue. What is the cause of mortality in scleroderma?
Pulmonary artery hypertension.
Yes.
Interstitial lung disease. Renal involvement.
Renal involvement, yes. Intercurrent infections. Don't forget intercurrent because of the immunosuppression which you're using. Intercurrent infections can be an important component. Okay, right. Dermatomyositis. What are the two types of dermatomyositis you know?
Adult.
Juvenile onset. Adult onset.
Which is preferable to have? Juvenile. Correct. Juvenile. Why?
Malignancy will be associated.
Yeah, good, right. And now coming to that point, you said there is no nodules or anything with discharging chalky material.
Sir.
You right now, what is that?
Calcinosis.
Calcinosis cutis. Calcinosis cutis. What is calcinosis cutis?
Dystrophic calcium deposits in subcutaneous tissue, mainly over the
Classify calcinosis cutis.
idiopathic dystrophic metastatic.
Good. So what type of calcinosis you get in scleroderma?
Dystrophic.
Dystrophic. Very good. How do you confirm your diagnosis of calcinosis cutis?
X-ray we can.
X-ray. Very simple X-ray. Radio opaque shadows you can get. Then you can do a biopsy of a nodule.
Sir.
And what stain do you use?
Vancosa.
Vancosa.
Vancosa stain. Or what is it? What does the calcium take? What color does the calcium take?
Black.
Black.
HA black.
Okay. Whereas pseudoxanthum elasticum also, no, you get calcium deposition. Am I right? You use Vancosa stain. Okay. How do you treat calcinosis cutis?
Calcium channel inhibitors like diltiazem can be used. Sir.
Yes.
Bisphosphonates,
Yes.
warfarin.
Cetrax and
And
Prominex.
less milk intake, less intake of calcium and other things, no? Antacids to prevent absorption of calcium. Antacids and calcium should never be taken together. So antacids themselves, no, the old time antacids prevent absorption of calcium, thereby also, or if they are painful and large, excise them. Excision of the nodules can be done. Dr. Guru Prasad, anything else you'd like to?
Sir, you almost covered entire.
Sir, you are also examiner. Whatever, normally I take the exam this way, take the students through the various gamuts of scleroderma. I must congratulate the postgraduate Ramiza. Wonderful job, very good presentation. And if you are going to have presentation like this and answer questions like that, I wish you get distinction.
Thank you, sir.
Yeah. Sir, Dr. Guru Prasad, please, sir.
Ramesha,
Sir.
what is, how do you say the patient is in renal crisis?
One is hypertension, sir, more than 140/90, or systolic BP more than or equal to 30 mm, and diastolic BP more than or equal to 20 mm mercury, sir. Then reduce the GFR, sir. Then raise the urea creatinine, sir. Blood urea creatinine. Hyperenemia, sir. Proteinuria. And clinically, the patient will have a fever, malaise, encephalopathy, retinopathy, pulmonary edema, renal failure.
Periorbital edema.
Regarding X-ray of the hands, what are the findings you see in the X-ray of the hands?
Calcinosis cutis we can see, sir. Then in distal acro-osteolysis can be seen, sir.
Systemic sclerosis is one condition where you see calcification as well as decalcification also. Both you can see in systemic sclerosis. And what about SLE and systemic sclerosis and pregnancy?
In pregnancy, gastrointestinal symptoms will be more, sir.
The patient is planning for pregnancy, will you advise continuation or any modification in the drugs?
If the patient is already on azathioprine, she can continue, sir. Low-dose prednisolone also she can continue, sir. And cyclophosphamide MMF should not be given for patient on pregnancy. So we'll maintain the patient on azathioprine, sir, if she is already on azathioprine.
Another point is avascular necrosis of the head of the female has also been reported, both in scleroderma, long-term, as well as in SLE.
Sir.
Of course, SLE, if you are using steroids itself can cause avascular necrosis. They may have to go for a hip replacement, THR or a partial hip replacement therapy.
When you advise bisphosphonates when the steroids are used, at what dosage?
If physiological dose of more than 7.5 mg prednisolone equivalent is used for more than 3 months, we'll start the patient on bisphosphonates.
Simultaneously, I think you can start bisphosphonates.
Prophylactically, we can start.
And then sir, any more?
Any other faculty can interact, no? Other faculty, from other colleges. Dr. Sitaram, sir.
Sitaram, sir.
Sir, I am here. I am there.
Sir,
Hello?
no more questions.
Yeah, no, Dr. Anand sir has covered everything. Today is yours. You take it.
I'm there.
Yeah.
Sir,
Hello?
no more questions.
Yeah, no, Dr. Anand sir has covered everything. Today is yours. You take it.
I'm there. Sir,
Hello?
no more questions.
Yeah, no, Dr. Anand sir has covered everything. Today is yours. You take it.
No more questions.
Sir, we have few questions from the audience. Sir.
Yeah, please, sir, please. Read out the
Dr.
question.
Ramya from Guntur want to know the role of biologicals and small molecules in systemic sclerosis.
Role of biologicals and small
Small
molecules.
molecules. JAK inhibitors.
Anti-interleukin 6 antibody tocilizumab can be. Then rituximab can be given in recalcitrant conditions. Imatinib, tyrosine kinase inhibitors like imatinib, dasatinib can be given.
Not many studies are there. Not many studies. Our rheumatologist here doesn't use. For SLE, she uses.
Right.
But for the scleroderma, no. More often than not, we dermatologists manage to treat. Unless there is a systemic involvement, we dermatologists learn. Another last this thing. What is morphe? For completion's sake.
Sir,
What is morphe?
morphia. Limited systemic sclerosis. Localized scleroderma.
Another thing is classification. What are the types of presentation of morphe? Linear, all those things you just have to read look for it. How do you treat morphe?
Methotrexate can be.
Very good. Methotrexate. Topical tacrolimus.
Tacrolimus,
Vitamin D and all.
potent
Vitamin D.
corticosteroids.
Yes, just for completion's sake. Because in the exam, morphe can be a spotter.
Sure.
Gupta Saab and all those things, you just have to for completion's sake.
Sure.
Completion.
Linear morphia involving the face
Yeah.
could be separate.
Contractures. If suppose involves the upper limb, there can lead to contractures. ILS, all those interlistheal steroid can be used in the places to prevent contractures. There also morphe also long pua. Long pua is useful, because of fibrotic component. Longer the wavelength, deeper the penetration. Pua, long pua is again used in morphe, localized scleroderma.
Dr. Tanuj Reddy from Rajahmundry want to know how many years of methotrexate can be given in diffuse systemic sclerosis. Any guidelines for starting methotrexate in systemic sclerosis dosage adjustment?
There are not many studies actually. Unlike psoriasis, no. We have to follow up the patient like as if we are giving methotrexate. Side effects of methotrexate has to be monitored. I have not had any patient of scleroderma who has taken methotrexate for more than 5 years. In my lab, because most of them land up with rheumatologists. They are the ones who use 7.5 milligrams or 10 milligrams of methotrexate. Just a point, methotrexate toxicity in psoriasis is much higher. Hepatotoxicity with methotrexate is much higher in psoriatic patients. Whereas rheumatoid arthritis patients, it is not there. Because of NASH, non-alcoholic steatohepatitis, which can be a component in psoriasis, methotrexate toxicity is not a problem for rheumatologists. They keep using it like water. We keep doing ECBC, this and all. Rheumatologists, I hardly find them doing many investigations. From methotrexate, there is no guidelines or anything, Like we follow for psoriasis, no? We have to use methotrexate.
Dr. Sai Sita want to know how to measure skin thickness.
Doctor, is there any instrument or anything you have?
20 megahertz.
Durometer, cutometer,
Like
glycometer,
20 megahertz.
elastometer, then 20 megahertz ultrasonography, optical
Optical.
coherence tomography can be used, sir, and clinically modified rodents.
Yeah, that's an important point. Ultrasound can be used to measure thickness of the skin.
Dr. Kalyan want to know the treatment of salt and pepper pigmentation.
I forgot to ask, what is the treatment?
Topical tacrolimus can be given, sir.
NBUV.
NBUVB can be given, sir.
Yeah.
Why does it occur?
Why does it occur?
Perifollicular capillaries preserving the melanogenesis, sir, and which is providing a high temperature. So, it perifollicular capillaries, sir, it's preserving melanogenesis and providing a relatively warmer temperature.
Dr. Saloni wants to know what is windmill maneuver.
To prevent Raynaud's, patient will keep his hand upwards and rotates.
What is the name given to the crackles in systemic sclerosis?
Fictional
Uh,
drugs.
Velcro
Okay.
crepitus.
Suppose the patient has ILD. What immunosuppressive you prefer, methotrexate or cyclophosphamide?
Cyclophosphamide, sir.
Why?
Methotrexate can cause pulmonary fibrosis.
Yeah, that's why. They have, suppose if they have any lung involvement, you should never, even though methotrexate is the commonly used drug for us, we should never try to give that if they have the lung involvement, especially the ILD, because it worsens further and it causes worse prognosis. Cyclophosphamide is a preferred one.
Can you explain the endoscopy findings and barium swallow findings in scleroderma?
Endoscopy, we can have lax lower esophageal sphincter can be seen, and due to gastric esophageal reflux, esophagitis can be there. And in long-term patients can have Barrett's esophagus, which can lead to adenocarcinoma of esophagus. And in stomach, we can see watermelon stomach, gastric antral, vascular ectasia can be seen. Mucosal atrophy will be there.
Thank you, Nana.
What are the topical treatment options for Raynaud phenomenon? Dr. KVT Gopal sir.
GT and
Topical glycerol trinitrate.
Management of pulmonary arterial hypertension.
Phosphodiesterase 5 inhibitors like sildenafil, tadalafil, prostacyclin analogs like iloprost, epoprostinol, endothelin receptor antagonists like bosentan, ambrisentan, macitentan, guanyl cyclase stimulators like riociguat can.
Dr. Pujit from Kakinada want to know when to stop treatment in systemic sclerosis.
cyclophosphamide only.
Cyclophosphamide can be given for a maintenance treatment for 1 year. And within 2 to 3 years, patient will reach a burned out stage.
Sir, Anandan sir,
Yeah, madam, I didn't, sorry, somebody interrupted me. I didn't have the question. What is the
when to
question?
stop treatment in systemic sclerosis?
When to stop?
Dr. Pujit wants to know.
When to stop treatment? It's a $1 question. I don't know. There are no biochemical measures or antibody titers or anything like that to say, unless there is no activity of disease, no. Personally, in the last 38 years of my practice, I have not had a single patient who has stopped treatment, only excepting 1 or 2. They're just on maintenance, either switch over from this to that, they're still on treatment, or most of them may have died.
Yes, sir. Treatment is highly individualized.
Individualized.
What is systemic sclerosis sign scleroderma? GL Rasagna wants to know.
No cutaneous manifestations.
Systemic sclerosis with no cutaneous manifestation, but internal organ involvement will be there.
What is Sharp syndrome?
Sharp syndrome is
Active
another
was-
name for MCTD,
and-
mixed connective tissues.
Okay.
Stages of nail fold capillaroscopy changes in systemic sclerosis.
In early stage, we can have isolated dilatation of nail fold capillaries. And in active stage, we can have megacapillaries, dilated and tortuous capillaries, and a decrease in capillary density. And in late stage, there will be avascular area and capillaries with multiple loop neovascularization, capillary dropouts.
Dr. KVD Gopal sir added topical diltiazem is an option for Raynaud's.
Yeah.
Is it available, sir? Topical diltiazem? Sir, Anandan, sir?
No, to my knowledge, it's not available. Or
Okay.
probably we have to, diltiazem is a calcium, this thing, no. We can probably ask our colleague pharmacist to make some topical preparation. This is a new lesson for me. I learned it today. Oral diltiazem, yeah, definitely oral diltiazem I have used.
What are the malignancies risk associated with
Topical Basentan can try, sir. We have tried that.
What are the malignancies risk associated with
Topical Basentan can try, sir. We have tried that.
Malignancies. Malignancies.
Sitaram sir, resound us.
Malignancies.
3.6 to 10.7% patients diagnosed. Reports between 3 to 10.
Lung carcinoma, non-Hodgkin B-cell lymphoma, breast carcinoma, oropharyngeal carcinoma, esophageal carcinomas, liver carcinomas are all associated.
3 to 10% of case reports.
Systemic sclerosis, the anti-RNA polymerase III antibody.
What are the oral cavity changes in systemic sclerosis? Dr. Shushmita wants to know.
In oral cavity, we can see telangiectasias can be seen in oral mucosas. Then sclerosis of the frenulum, which will lead to difficulty in protrusion of tongue, can be seen. And due to reduced mouth opening, poor oral hygiene. Then in X-ray, dental X-ray, we can see Staffney sign. Widening of the periodontal space, which is filled with a thickened periodontal membrane. And sclerosis of frenulum also can be seen in X-rays.
So, doctor, OPG, no, dental, no? You do a OPG, oral phantomogram. There you will sit Stepney sign.
Sir.
Where I remember I was a guide to one of the oral pathology postgraduates. They compared the SMF, submucous fibrosis. There is a condition called submucous fibrosis, pre-malignant condition, with oral mucosal involvement to scleroderma. These are closely related conditions where thickening of the oral mucosa and other things happen. Of course, I don't know the pre-malignant potential of oral involvement in scleroderma. SMF, definitely there are chances of turning malignant. So, Staples sign, OPG, you must add to the investigation.
Sir.
Dr. Girish from Nandyal asked to define stiffness, thickness, induration, and hardness.
Yeah, what is the answer?
Okay. Any other conditions like sign, scleroderma, other signs?
Josteri sign
Herpes zoster
zoster.
in
Without any cutaneous eruption, they may present with pain.
and dermatomyositis in myositis.
So Dr. KVT Gopal sir has added that diltiazem gel is available as a crema gel in trade names. CREMAGE, crema gel.
Oh, that's a good news.
Dr. Banu wants to know any experience on topical nifedipine in calcinosis or Raynaud's. Sir. Anandan sir.
Topical nifedipine. I don't have, sorry, I don't have any experience.
Topical nifedipine we don't have, but we have the topical sodium disulfate we have used in the calcinosis cutis. The same sodium hypo is available. We made it into 25% and then apply twice a day. And usually in 3 months' time, the tenderness and pain decreases. Even the swelling also decreased. So the calcinosis cutis, that can be tried. That is easily available, very freely available. So topical 25% sodium disulfate.
Okay, then conventional hypo.
Yeah, hypo.
What is Samit sign?
Samit sign.
Cracked cuticles. Seen in mainly in dermatomyositis, can be seen in scleroderma also. Other connected.
Barnett neck sign.
Visible and palpable tight band seen over platysma on hyperextension of the neck in systemic sclerosis.
Okay. What are the nail changes in systemic sclerosis? Dr. Satyaprasad from Guntur sir has asked.
Inverse pterygium can be seen. Then rounded finger pat sign. Not nails, fingertip chains. Paronychia can have Raynaud's ulceration.
Pseudoscleroderma conditions. Dr. KVT Gopal sir has asked enumerate conditions which cause pseudoscleroderma.
Okay, I think this is a commonly asked question. Pseudoscleroderma. You told.
Morphia, pansclerotic type of morphia. Then nephrogenic systemic fibrosis, sclerodema, scleromyxedema, chronic graft versus host disease, eosinophilic fasciitis. Then Then sclerodermoid genodermatosis like acrogeria, progeria, Werner syndrome.
Skin stiff
Then
skin.
stiff skin syndrome. Acrodermatitis chronic atrophic and sporphyria cutanea tarda.
Dr. Luluva from Delhi is asking, what is 6-minute walk test?
The good.
It's done to know about the lung capacity. Patient is asked to walk to and fro for 6 minutes, and normally patient can go about 400 to 700 meters, and it will be reduced when lung capacity is reduced.
Same. Dr. Luluva is also asking how to objectively assess skin tightness.
Cutometer, elastometer,
20
20 megahertz ultrasound sonography, optical coherence tomography.
elastometer.
Name repeat of the position.
How to demonstrate Raynaud's phenomenon and how much cold for what time you should keep? Dr. Luluva has.
Whether we can do
In 15 degrees Celsius for 1 minute.
and is it ethical to do demonstrate Raynaud's?
No, sir, we should not elicit Raynaud's.
Only on seeing the symptomatology, we can know that patient is having Raynaud's phenomena.
Sir.
Spot trial, scleroderma
Dr. Dhriti is asking, what is Scott trial and Quinn's trial?
Scott trial is scleroderma, cyclophosphamide, and autologous hematopoietic stem cell transplantation trial. And Quinn's trial is quinaprine is used. Quinaprine is used.
Types of telangiectasias in systemic sclerosis. Dr.
Telangiectasias are seen in systemic sclerosis, which are seen over a face, lips, oral mucosa, trunk, fingers, palms.
The questions.
We are done with the questions from the audience, sir.
Okay, that's a great thing.
Sir, anything
So we give just 2 minutes for the audience to post any other questions. As
Yeah, please.
meanwhile, you can say, give some message, sir, to post-graduate, all the post-graduates, because most of them are post-graduates only. Sir, Anand, sir.
I must congratulate the effort of IIDVL Andhra Pradesh to have started the PG clinics, and that in the right earnest with a long case presentation of scleroderma by Dr. Ramiza. And it was wonderful. It's a good learning experience for me. Actually, I send the link to my postgraduates. My postgraduates are also attending. Because for them, if some postgraduate presents it as well as what he has done, I said no, it's 50% true. If the answers ask like that, it will get distinction. It's wonderful. I must congratulate Dr. Sitaram, President and Secretary of IADVL Andhra Pradesh, for having initiated this particular program. I'm thankful to you for inviting me to be the external expert for conducting this particular program. One of my favorite topics is scleroderma. Hope I have done justice to my role as an external examiner today. Thank you.
Sitaram sir to speak and
Sir Sitaram sir, few words for
Yeah,
all.
the questions are already done.
I
Questions are over. So thank you, sir. Thank you very much, Anandan sir, for being with us today. It's a wonderful discussion. All of you, We all have learned so much with all your fast questions immediately, and then it's proper. I mean, everything is explained in detail. Of course, Ramiza has done wonderfully well. I think she's still only in second year, I hope, but she has done extremely well. The case presentation in detail and the preparation for the discussion. So, well, this is all what we are looking for in future programs also. So, Anandan sir, thank you very much for your participation.
Thank you, sir.
It's really wonderful today. I mean, when Guru said that, sir, I would like to invite Dr. Anandan sir. I said that is the thing which we wanted. Please, most welcome. And if he starts the proceedings, and that will go in a long way. So that way, it's very fortunate that you are with us today here, sir. I hope all the postgraduates have enjoyed the discussion, and we will continue these things once a month, every time, with different types of cases and the spotters also. Guru, anything you want to say, Guru Prasad?
Thank you very much for giving us opportunity. Andhra Medical College, being in the centenary year, we are privileged
Oh.
to be the first to host the meeting. Thank you very much, sir. Yourself, Kavita madam, and Saujanya. Saujanya is anyway our student.
Yes, sir.
I should thank you. Soon after I proposed this, I mean, tell all the people here. So I just proposed in the morning on that day, and by evening he came back with, I said, we will do on this and this date with Professor Anandan sir. So that was the promptness and fastness that Guru Prasad acted. So thank you very much, Guru Prasad, for your excellent support to the academics and excellent support to the IADVL AP. Over to you, Saujanya and Kavita.
Yes, sir. Thank you, sir. That was a wonderful learning experience even for us now after so many years. I thank our examiners, Dr. Anandan sir and Dr. Guru Prasad sir, and postgraduates, Dr. Ramiza and Nandini, for coming forward to present the case. Dr. K.S. Divya for looking after the proceedings smoothly, and our dynamic president, Dr. Kavita, who made this happen, and Sitaram sir for encouraging and guiding us all the way. And not but the last least, thanks to Gloderma for the technical support, and they arranged this platform without any hiccups. And they promised to do these PG clinics all around the year. Now I invite Yogeshwar, Marketing Manager of Gloderma, to say a few words.
Thank you, madam. Thank you very much for giving us an opportunity to provide you the technical as well as educational support to this program. And I hope you must have enjoyed this uninterrupted services, as well as you must have seen the overall support what we have. And audiences also, that I would like to, I'm pleased to announce that there is around 380 live attendance to this program. And that was a tremendous response so far as the program is concerned. And this is only first actually lecture of this series, we can say, organized by IADVL AP, that is PG clinics, in the form of PG clinics. All the doctors, I sincerely thankful that giving us an opportunity. And I will say that stay tuned for next lectures also. IADVL PG clinics in January, date will be announced soon. That will be shared with you all the attendance. And please be with us with your valuable support and valuable blessings. Thank you very much.
Thank you, Yogeshwar. Thank you, one and all.
Thank you. Thank you so much.
Yeah.
Thank you, sir.
Thank you, sir.